Welcome to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. And a reminder to new listeners that Kentuckians for Single Payer Healthcare is a nonpartisan group, and we are an affiliate of the Kentucky chapter of Physicians for a National Health Program. We support a nonprofit, expanded and improved Medicare for All system, one that covers all individuals residing in the U.S. We advocate that the program cover all medically necessary services, including primary care and prevention, inpatient and outpatient care, emergency care, prescription drug coverage, durable medical equipment, long-term care, palliative care, mental health services, dental services, substance abuse treatment, chiropractic services, vision and hearing services. Kentuckians for Single Payer Healthcare supports an improved and expanded Medicare program that provides care with no deductibles, no co-payments, no co-insurance. A true single-payer plan. We're broadcasting our program from the Hayburn Building in downtown Louisville as part of the nonprofit programming here at WFMP 1065 forwardradio.org. The views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard on WFMP 1065 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal, you can live stream us at forwardradio.org. And if you miss a show, you can go to the Forward Radio archives. We're up on the SoundCloud there at forwardradio.org. WFMP is an all-volunteer station. We rely on the community for your ideas and funding. Join us. Go to forwardradio.org. Doctors Mike Flynn and Gene Shively are back in the studio, zooming in today's guest. Mike?
This is Michael Flynn, retired surgeon from the U of L Department of Surgery. Let me begin with the usual disclaimer that any comments that I make or opinions I express on this program represent my personal opinions and do not represent the opinions of the Department of Surgery or the University of Louisville.
This is Eugene Shively. I'm a retired rural surgeon, Campbellsville, Kentucky. Had a clinical appointment to the Department of Surgery at U of L. What I say does not reflect the Department of Surgery at University of Louisville, nor Taylor Regional Hospital in Campbellsville, Kentucky.
We have a special guest today. Melissa Patrick is a journalist. She is a staff reporter for Kentucky Health News. Interesting background. She was a nurse, practiced in the late 1980s and early 1990s, went back to school, got a degree in journalism, community communications, leadership, and development. And our topic today is a recent article that she had written and was published in Kentucky Health News, dealing with the Kentucky health system performance compared to the rest of the U.S. So, Melissa, welcome. And again, thank you for coming on and discussing this important issue with us. As we've done with guests in the past, we're going to give you an opportunity to make whatever comments you'd like for as long as you like. I would ask you, though, since most of our listeners, I don't know this for sure, but I'm assuming some or a lot anyway, probably haven't read your article. So I think it would be helpful if you could kind of give an overview of the main issues there so that the listeners have an idea what we're going to be talking about, at least for part of the time. So the floor is yours.
Well, thank you for having me. I've been at Kentucky Health News since 2014 and came into this journalism career a little late in life, but I've sure loved it. And I write from everything from diabetes to health policy. And this particular article falls more into health policy because the Commonwealth Fund, which is a New York-based foundation, does these rankings every year, an annual ranking on how health systems perform in each state. And basically, the Commonwealth Fund is looking to answer three questions. How good is your access to care in each state? Are Americans getting the right type of health care in the right healthcare setting and at the right time? And then they want to know just in general, how healthy are the people in each state? How healthy are Americans? But because COVID hit, it gave them just a very unique opportunity to see what a public health emergency, the impact of that public health emergency on our healthcare systems. So this year they also added a category that basically looked at how our healthcare. So generally, there was no surprise in where Kentucky ranked in this particular ranking, which only, it takes into account, it doesn't take into account other than the one category, sort of the basic standing health status of Kentuckians. It just looks at how the systems are managing what they have to deal with. And so it looks at that, found Kentucky ranked 41st out of all states in Washington, D.C. And that is not surprising. That's kind of where we fall most years. But when they looked at the COVID-19 response, even the researchers were a little bit surprised that Kentucky ranked so low because for several reasons. Kentucky ranked 49th in that category. So in essence, this report says Kentucky has done a very poor job managing its COVID-19 response. But one of the researchers just expressed complete shock about that. She said most states that have expanded Medicaid, which means that they have allowed more poor Kentuckians to have access to health care. They expanded the number of people who can have health insurance, had actually done better in their category of COVID response. But Kentucky, which did expand Medicaid and increased the number of people on insurance dramatically, didn't do so well. And so this particular researcher said you have to look at the whole picture, that it's not that having health insurance certainly improves access to care, but there's more to talk about. You have to talk about personal choice. You have to talk about the baseline status of health of people. And so that was just a real interesting finding in this study. It looked at all sorts of things from hospitalization and readmissions. It looked at dental care. It looked at just simply access and affordability. It's a comprehensive report. Once again, Kentucky ranked 41st overall, and that's not surprising.
Jane, you want to begin?
Yes, I was really interested in that Kentucky had expanded Medicare almost more than any other state, and we were one of the first to do that. So it increased availability for healthcare, and it also increased or decreased the number of patients with no insurance. Yet our outcomes did not change. We're still doing terrible, and particularly with COVID, we do bad with obesity, hypertension, and smoking and multiple other diseases, including drug addiction and suicide. So my question is, what are the other factors? What are we leaving out that keeps us in such a very low rating?
Well, I recognize that the black and white of the health outcomes in Kentucky the needle has not shifted. But I think to simply to dismiss the expansion of Medicaid as not being an important thing is a little bit of a too narrow way to look at that. People can't access care to physicians and have primary preventive services, have a primary care physician, stay out of the emergency room, treat their chronic health conditions. You can't do that very well if you don't have health insurance. And so the expansion of Medicaid is instrumental for all of those things. So then you come to, well, we've had it since 2014, and here we are in 2022, and the numbers haven't shifted. So what are we doing wrong? Well, anyone who talks about healthcare knows that simply having access to healthcare isn't the only solution to the problem. You have to look at it holistically. You have to look at what they call social determinants of health. And when you make a commitment to changing health outcomes for anyone, you have to look at housing, you have to look at transportation, you have to look at whether they have access to healthy food. Then you have to look at their culture. If the culture is to eat a diet that promotes heart disease, then how do you meet people where they are to change those habits? It's not so simple. The other thing is health outcomes take many years to change. And so I don't know when we throw the towel in, but at some point, more people getting preventive services, more people seeing a primary care physician has to make a difference at some point.
Let me make a comment about the pandemic management in the state, and then ask you to make a comment about my comment, my views. I thought that the governor did an outstanding job communicating with the populace in the state. They used resources, I thought, appropriately. On the other hand, the legislature spent most of his time trying to restrict the governor's activities. Now, I don't know how much impact that dysfunctional relationship had on the outcome, and I'd be kind of curious about your views on that from the standpoint of a journalist. So, what are your thoughts?
Well, and so that's what this particular report that I wrote about, it didn't take into account personal choice, because certainly in Kentucky and legislative measures, it didn't take those things into account. It simply looked at how it is, like the numbers as they stand. And so, and it didn't, that's okay. It measured what it measured. But the reality is in hindsight, and that's, worth nothing. But in hindsight, if our legislature and our governor could have found a middle ground, a place to work together on this issue, I can't fathom that it wouldn't have made a difference, especially around vaccination rates and compliance with masking. Because as health providers and public health people know that those two things are, they work. They've been proven to work to decrease COVID in our state and to decrease severity of the disease and hospitalizations. And so I would have to say that, there was a Kaiser Family Foundation poll or story that just came out this week that found that Republicans in particular simply are at a point in the COVID process where they do not trust government sources for health information about COVID. And so therefore, there's a population of people who simply need to get that information from a trusted source. And so it sure would be nice if everyone was lined up, whether it be a lawmaker, the governor, the public health director, everyone lined up on the same page to give the same message, which is vaccines work, go get one.
Yeah, I agree. It wasn't just the state of Kentucky. We had this on a national level in this country. I mean, some of the stuff that was coming out of the White House you make your head explode. Let me ask you another. Let
me just
go
butt
ahead,
in here
Jane,
for just
sure.
a minute. My wife and I developed this political cartoon of a patient. There were 4 pictures. A patient went to his doctor, and the doctor said, "Why didn't you get vaccinated?" And he said, "Well, I don't know. I just didn't." And then the next picture shows him with COVID, and the next picture, he's on a ventilator and he dies. And he gets to heaven, and he says to God, "Why didn't you save me?" And God says, "Well, I gave you 2 good vaccines. Why didn't you take them?" And my experience in rural Kentucky is some of these people just will not take it, regardless of what you tell them.
I have reported on some of that. You know, when you're asking, to your first question, when you ask about telehealth, did it have an impact? Like, what is your question? Did it have an impact on what? On access to care or COVID vaccines? I need a little clarification on that.
Access to care and information regarding COVID.
So I can't speak to access to information regarding COVID because, quite honestly, that responsibility, in my opinion, falls to a physician every time he speaks to his patient. And when a physician doesn't take that opportunity to speak on a very personal level, meeting the patient where they are, no matter whether they're strongly against it or sign me up, those opportunities were there for doctors every time they got on a telehealth phone call. I don't know if it happened. So but regarding to access to care, the federal government, Kentucky's been rather progressive in parity and pay and a lot, sort of being a little bit more progressive in the telehealth field than maybe some other states. But the federal rules that allowed people to have a telehealth visit on their telephone, like prior that hadn't been allowed, or to allow a patient to take to have an appointment in their home instead of having to come to a clinic to have the visit. There were changes that did make it easier for people to have these visits. And yes, I think most places report that the number of visits went up, and that means access to care. That doesn't mean everyone took advantage of it. There are barriers to telehealth care. A lot of times seniors are seniors are resistant or nervous or need more education on how to manipulate their phones and their computers to get telehealth done. But I think that many of them also just stepped right up and made it happen. So there's lots of discussions about what all of that will mean going forward.
Yeah, we had a retired internist on the program, it was probably 9-12 months ago. And she had said very much the same things, that there was just a lot more contact with folks who might not have, for one reason or another, and this was during the pandemic, been able to have gotten medical advice just because they could simply do it on their phone or on
Mhm.
their computer or whatever opportunity they had to do that without having to get into a car or a truck or a bus or walk to get to a physician's office. Let me your article on the very first page. There are three questions that apparently that are asked by this was it the score bar card state health system performance. And the first one here is, do Americans have good access to health care? Does their health insurance enable them to get the care they need to stay healthy? Well, I want to share with you one of my rants about U.S. healthcare and get your views about this. Unfortunately, in this country, we do not have a healthcare system. Most of the other first world countries have healthcare systems that focus on providing care to their citizens. We could go through a whole list of the different ones. I'm not going to do that. Unfortunately, in this country, we have a healthcare industry which is focused on extracting profit from healthcare activities. And there's a gazillion examples about this, but I just want to give you one example. Then I'd like to get your views about this. Probably the most outrageous example are the for-profit insurance companies who literally extract, and Gene has got some really good data about this in a sort of global sense. They extract hundreds of billions of dollars out of healthcare for an assortment of non-healthcare activities, from outrageous CEO salaries of $30 million a year, political contributions, administrative activities, on advertising, on and on and on. And let me ask, what are your thoughts, again, as a journalist, about our system of healthcare industry versus a healthcare system where most other first world countries have this run by the central government?
Well, my first my first response would be, our health and hospital associations have tremendous lobbying power, and so the challenge, and generally as a people, we don't like change. We know how things are the way it is, and we've kind of fallen on the haves and the have-nots of who gets care. And I'm not going to say people are comfortable with that, but they're certainly familiar with it. And so making any sort of drastic that moves toward a different way to do it, to provide universal coverage, to increase primary care and preventive care, to look at those social determinants of health as a thing that needs to be provided and paid for, or to reduce those administrative burdens that you've talked about. Like any holistic movement to provide those things initially will be very, very painful. And so I don't know. I think something will happen. I think that at some point the whole healthcare system, we've all journalists have written that statement that among high income countries, the United States spends more on healthcare than any other country and has the worst outcomes. And
yes, absolutely.
We've all written that at some point.
Sure.
And you can find documentation from that from numerous sources online. So something's going to have to happen. I don't know when it will happen. I know there's a energy and kind of movement toward that, but we're so divided right now. When you have a country that's sort of split down the middle on ideation, it's hard to get movement forward.
I agree, and it's going to take a long time. Gene, you want to make a few comments about your you had the financial information that you've shared us on a number of occasions on this program, kind of where the money goes in healthcare in this country.
Well, we spend about $3.6 trillion. I'm not sure I could sit down and write that down, how much money that is. I've forgotten how many zeros go in
Well, it's a lot more money than you and I ever.
there. And I got interested in the amount of money being wasted in healthcare. And these are gross numbers. It's impossible to get exact numbers because it changes every day, and it depends on how one interprets it. But approximately a third of that money is wasted and has nothing to do with healthcare. One example is all the profits that insurance companies are making. No one else makes healthcare a profit margin. They're all nonprofit, where if there's any money made, it goes back into the system. It would go back into reducing the cost of the premium or expanding benefits. Another example is advertising. We're the only country in the world where doctors, lawyers, drug companies advertise to the community on a broad base. Only New Zealand, as far as I know, allows that type of advertising, and they only allow drug companies, and I don't really know why. But we waste a phenomenal amount of money doing that. And if we just took that amount of money and applied it directly to healthcare, we could probably pay for the whole system and may even save some money.
That's a really scary thought. From a journalistic standpoint, have you got some thoughts about what Gene just said? I mean, it's the question really is, what do you do about it? And I think we all agree, whatever happens, it's going to take a long time.
Right. Well, Senator Meredith is always working to decrease administrative cost in our Medicaid managed care organization system. He insists that if we can get, he's conceded to having only 3 managed care organizations. What do we have right now? 5 or 6? But he insists if we could just even skinny that down to 2 or 3, then all of a sudden you're getting rid of a whole lot of administrative costs. So there's always someone with a suggestion, but that's like a drop in the bucket. That's, when I hear ideas like that, I'm like, well, that's just, one skinny little piece of the problem. And so, but is that how it's going to get? Is that how we move forward? Is a little piece at a time, is to fix a little piece at a time? I don't know. Then beyond that, if we were to get rid of insurance companies in a system where it's all, I'm imagining it's all a government system, like that's what I imagine that we're maybe talking about here. If we got rid of all of the insurance companies, then that's a whole population of people who don't have jobs anymore. What happens to them? And so I don't know the answer to that, but there's so many layers of challenges to this particular issue that I'm just not sure how. I'm just not sure how it will resolve going forward.
Yeah, I don't think you have to get rid of insurance companies. Canada and Australia both established universal healthcare systems in 1984. That was a while ago. So I guess you were still practicing as a nurse back in those days. And they're similar but different. In Canada, they cover hospital and physician costs, and you need other insurance for drugs, sight, hearing, and some of those other issues. And in both Canada and Australia, and in Britain, the National Health Service and a whole bunch of other countries, there are insurance companies. They're just not for-profit insurance companies, or if they are for-profit insurance companies, the government run insurance, which is competitive, is a good competitor to the extent of the profit that the insurance companies extract out of the system. Just another example that, Gene been practicing down in Campbellsville for 35 or 40 years. Australia has a Department of Rural Health. Now, rural health in this country, I'll let Gene, he knows much more about that than I do. It's really got some problems. We've talked about that a little bit already, with no specialists, transportation issues, financial issues, hospitals closing. They focused an entire governmental department on making sure that there's good health care in the outback. So we don't have to get rid of insurance companies. They just need to be not allowed to run the system.
Another example of a non-for-profit insurance company is Germany and Switzerland. They have a lot of insurance companies which patients can choose, but they're all not-for-profit. And it's like the old Blue Cross Blue Shield. They went for-profit in the late 90s, I think. But prior to that, if they made money, the money went back into the system to decrease premiums and increase assets. All that's gone now, I think. Do you know of any non-for-profit insurance company?
I don't. I mean, there may be some, but I don't know about that. Melissa, have you had an opportunity as a journalist to get out into the rural parts of the state? I've always wondered what people are thinking in rural Kentucky, and I've talked with Gene about this a little bit, and I know kind of some of his views, but as a observer of activity as a journalist, I was wondering if you've been out there, because you wonder, there's so many issues. Why do they keep putting people in office who make policy that is against their economic and health interest? And I just, for the life of me, don't understand. I just wondering, have you had an opportunity to get out there enough to get a sense about this?
Well, no, the way Kentucky Health News is set up, I'm only I only work part-time. And so my hours are a bit limited as far as doing that sort of field work. Hope is that when I write an article, and then it shoots out to every newspaper across the state, is that they can take my article as a foundational piece and then go out into their community and ask those questions. But, we all know that staffs in rural community newspaper rooms are diminishing and even closing. And so the challenge there is that while I am not the person who generally goes out and asks those questions, we have newsrooms that are so small, and their time too. So time and budget and resources are so limited that they're not oftentimes taking the time like maybe they were able to 40 years ago to go out and ask that question. So what I'm trying to get to is, yes, there are a lot of reasons for, in particular, simply asking, why did you vote for who you voted for? Just simply what drove your decision in that vote? And then even saying, are you aware that that if you vote for this person, they're against or for these certain things? Those questions need to be asked. And right now, I guess broadly speaking, I don't think they're being asked.
Well, I can tell you that most elections, at least local elections in most rural communities in Kentucky are based on not issues, but friendship and certain local issues and getting roads paved and gravelled, etc.
Right, right.
Well, but healthcare is in this country today is a really important thing. We're all getting older. More and more people, Gene, are looking like you and me. and Mark and Melissa. But that's why I just don't understand. I don't understand that.
Well, I think most people don't think about what's going to happen when they get older. They don't think about getting cancer or getting sick. And then when they get it, they don't know what to do. And that's we have to guide them through that. But I don't think that, and most people even think about preventative care. It's something that doesn't cross their mind, particularly young people. They
Oh, and I can add too that for years and years, people have depended on their emergency rooms for their care. And so even though someone doesn't have health insurance, they are they can't be turned away from an emergency room environment. And so they simply, if they have the flu or if they, have whatever sort of health condition come upon them, that's where they go for care. And therefore, the emergency room ends up taking a loss if they're not able to pay for it. And as everyone here knows, the cost of care in an emergency room is exorbitant. It's just not. It's not the way to go.
Well, the culture on that has really changed. I went into practice in Campbellsville in 1978, and the family doctor had personal relationships with their patient, and he was in control. I know several family doctors, if they had a patient that went in the emergency room and didn't be there, he would scold them. Like, for example, if a patient showed up in the ER with a rash, he'd tell them, get out and come to my office tomorrow. But you can't do that anymore. You can't control the patients. The patient and administrators are in total control.
Melissa, let me ask you another question about another aspect of medical care in this country that has changed during the time that I've been in medicine. When I went through my training and came to Louisville, physicians basically ran their own practices, had small practices, different size ones, and I was in private practice for a number of years before I joined the university. Today, most physicians work for somebody else, whether it's a hospital system, a healthcare system, they're private equity organizations running practices. So, because when I was a president of the medical staff at one of the Louisville hospitals, we could go to administration and they listened to us. We had influence. And I remember at this way back in the 70s, people smoked in hospitals. Mm-hmm. And as a chairman of the cancer committee, I went to the president of the medical staff. And I said, this is crazy. Had cigarette machines in the hospitals. And, and the problem was there were some people from the tobacco companies on the board of directors. But anyhow, they took them out, and we did have influence like that. Today, a lot of that's gone. If you're getting a paycheck from one of these systems, whether it's a hospital system or a healthcare system, one example that I experienced before I retired was they would, quote, encourage, unquote, you to refer within the system.
Mhm.
And I did some very specialized surgery, and I would see changes, pattern changes where people wouldn't be referred as much. And then maybe at 6 months later, some of the unexpected or unhappy consequences of having something done by somebody who wasn't that experienced occurred. I'm just wondering, from a journalistic standpoint, have you had, has that something that's crossed your path? Have you had some thoughts about that, or had any opportunity to kind of get a sense about how medicine is different in this more corporate run medical care today than it was 20 or 30 years ago?
That's not something I've written about. However, just, it's brought, just sort of anecdotally or just from having had conversations with physicians over the years, as you well know, the decision of a physician or a physician's group to join those big systems is influenced by trying to make similar money that they could have made years ago, that they're just simply
Yes.
without being part of one of those systems, and also influenced likely by malpractice protections, having sort of a bigger group to to cushion some of that maybe, but it's sort of been my understanding that a lot of that's just simply been driven by the economics of being a physician right now, trying to survive in this post-ACA world.
I think part of the issue is the complexity and the time that now the average practicing physician has got to spend doing this electronic health records process, which is focused mostly on billing and not on healthcare. Gene, you got
There's
some
no
thoughts
question
about that?
one of the biggest issues is time. If you're in private practice, there's literally not enough time to code and to do electronic medical records and to do all the pre-authorization, et cetera, and your overhead goes way out of sight, and you it's hard to break even. And that's to the point that unless you're in a very large group, you can't do that, and you have to depend upon a hospital. Now, there was one other thing I wanted to talk about. We were talking about tobacco. Now, you got to realize that we've had a tremendous cultural change in tobacco. Most people don't smoke now, even in rural areas. And I remember the day where several doctors grew tobacco. I remember the day when doctors smoked in the hospital, when the Red Cross ladies would give cigarettes away in the VA, and that's all changed. And
well, that's a good thing.
Yeah, but so maybe we can change the attitude of vaccination. The average person doesn't really realize how important vaccination is. The reason that all of us have gotten to the age that we are is because of vaccination and control of infectious disease and good water and good sewers. And we all seem to think it's due to surgery and modern drugs. Obviously, they make tremendous progress, but still, if you don't have good water, you can't fix everything.
Well, listen, let me ask you again, give you another opportunity to make some comments on what I consider a really interesting and worrisome aspect of medical care today. Now, we're in the post-Roe versus Wade world. One of the things that I've been trying to do is to get some guests to do a program with us on women's health issues post Roe versus Wade.
Mm.
I have one retired physician who is not an obstetrician or gynecologist, who has a personal story. And I've been trying to get a female obstetrician gynecologist to come on and discuss these issues. And that's been very difficult. And
Mhm.
they don't want to. Some of them have professional fears, and some of them have personal fears about this. I wonder if this is something how does this fit into the journalism world that you live in?
Well, I think when journalists go to speak to people who support abortion rights, often they'll go through the ACLU or through Planned Parenthood, which are organizations that are very vocal about what they believe to be appropriate health care for women. And so I think so finding a physician or finding someone who can speak to that topic when you go through one of those organizations is not, I think that's where most journalists lean toward. I think the challenge, of course, is when you are trying to find simply we'll just say an emergency room physician who is right now struggling to related to the health of the woman. That's just a real struggle they're having right now, and the federal government's tried to clarify that, but it's still there's still just so much uncertainty around that issue. So those physicians who don't perform abortions regularly are the ones who are probably going to be really hard to want to put their voices out there.
I read an article just the last few days where a patient in Texas had a miscarriage but had retained fetal products, and she couldn't find anybody to do a D&C for her.
Mm-hmm.
And the ultrasound showed that the fetus was dead and deteriorating.
Yeah, I mean that you can die from that.
Right,
That gets infected, and,
Right.
and you can get sepsis. It's really scary. Some of the rules that various states are put in place, not just dealing with the individuals in their states. I don't understand this law that they've got in Texas that allows a private citizen to sue somebody in another state who helped someone from Texas go to whatever state it is and have some kind of abortion care that's illegal in Texas.
Mm-hmm.
I mean, it's just. Have you thought about some of those things from a journalistic standpoint, or had to deal with that at all?
I haven't, but my I made sort of flippant remark to my boss that this legislative session might be full of such law bills,
Yeah.
which will not allow a woman to cross state lines to get an abortion. And my boss was like, oh, that's he just couldn't even believe that was real. And if you will peruse the journalists who regularly write about abortion, we're seeing this discussion creep up everywhere about potential restrictions put on women to cross state lines. And so will that come to pass? We'll see.
You wonder who do they go after? I understand the physician who would either provide the pills or do the surgical procedure, and then maybe somebody in the facility. Now, if this woman takes a Uber from her hotel to the,
Yeah.
place, does it involve the Uber driver or the person in the hotel who checks them in? When you think about this, this is a draconian kind of I mean, this is almost like Taliban. The women are going to have to be wearing towels on their heads. It's just fascinating.
Well, I will simply say, yes, it is fascinating, but it's also these are humans, these are women who need health care quite often, and this type, abortion health care, and they are they're being faced with decisions and transportation costs and organization costs, and that all of that takes time. And to have a medication abortion is less than 9 or 10 weeks. By the time you work through all of the processes to get to a state that you can have an abortion, sometimes you move over into that 11th week, that 12th week, which means that you need a different type of abortion. It can't be a medication one anymore. So it's fascinating, but these are real people that are having to make these decisions every day.
Oh, and it's what's really scary is what Jean's talking about, because if a woman has got an ectopic pregnancy and there's a heartbeat, some of these draconian rules say that you can't do anything if there's a heartbeat. Well, if that ectopic pregnancy in the uterine tube ruptures, that can be fatal. In the same way. Go ahead.
And there are journalists writing that exact story already. That's happening. That's not a thing that's not a hypothetical. That is a thing that is happening.
I'm glad that is. And if the water breaks and they have a miscarriage, and now if those contents stay in there, then they get infected, or they could bleed, and either or both, and either or both of those can be fatal. It's really scary to think that of the politicians who are making these laws about something that they really don't know very much about.
Mm-hmm.
I want to tell you a quick story about that. We're running short on time here.
I got one other issue I want to bring up.
Go ahead. I've told this story before. There was a surgeon in Louisville many years ago who retired. And Mark has given me the 4-finger sign, so we're getting close to the end. I'm going to tell it very quickly. And he ran for public office. He was elected. I'm not going to mention his name. He gave a talk at the Louisville Surgical Society many years ago and told us 2 things. Number one, which we've heard before, making laws is like making sausage, and how he sponsored a law. By the time it went through the committee system, it had changed so much he voted against his own. And the other thing he told us, which is the purpose of my comment here, is that the politicians do not know anything about healthcare. He's very clear about that. People, they own garages, they're lawyers, they have an assortment of other business opportunities. They really don't understand healthcare. Jean, go ahead.
In your article, you mentioned dental care. Can you just comment about that?
Well, I can. It's still shocking to me that health insurance doesn't always involve providing dental care, because we pretend like the mouth isn't part of the body or a part of our health system. And we all know, as time has passed, that, when you have a tooth infection, it affects your whole body. So in particular, there's a lot of discussion right now about trying to increase rates for Medicaid, dentists to accept Medicaid. Nationally, there's a number that about 25 to 35% of dentists accept Medicaid, but the reality is it's much lower than that, because some of them have a number and they have the number, the Medicaid number, provider number, but they don't use it, or they only take 1 or 2 patients. it's a real problem, especially among our poorest Kentuckians who so desperately need dental care and have such a hard time finding it.
Melissa, I think we're about the end of the time here. I want to thank you again. You've been a great guest. We've enjoyed talking with you. Your article is great, and you've made a lot of good, clear points. Mark's going to take us out of here.
Thanks, everybody. Great job. Now, other countries with forms of universal health care coverage may require supplemental insurance for services not covered. But to repeat, Kentuckians for Single-Payer Health Care supports an expanded and improved Medicare for All program for all medically necessary services with no deductibles, no co-payments, no co-insurance, a true one-payer system. And to Melissa's issue about a Medicare for All program creating unemployment there in the insurance industry, some of the legislation has been proposed to address that, to retrain and reemploy workers displaced due to reduced administration, and include employment transition benefits up to $100,000. You can learn more about Kentuckians for Single-Payer Health Care and our campaigns by going to our website, kyhealthcare.org, kyhealthcare.org. You can follow the group on Facebook, Twitter. We meet twice each month using Zoom. And if you'd like to attend a meeting, you can reach out to Kay Tillow. She's our chair. And Kay's email address is nursenpo@aol.com. nursenpo@aol.com. Kay would send you an invitation to a meeting. And for Single Payer Radio, I'm Mark McKinley. Thanks for listening, and please support your local nonprofit independent media outlet. Community interest, not stockholder interest.